part of the respiratory system, and things like that, right? So essentially, the lungs are found within your thoracic cavity. And the thoracic cavity is also where you find your heart. The heart is sitting in the mediastinum, the lungs are sitting laterally to the heart itself in the thoracic cavity. It is covered by a connective tissue layer, right? Actually, it's covered by two connective tissue layers, which are actually continuous with each other, so it kind of folds onto each other. One side of that connective tissue is actually stuck to the inside of your thoracic cavity, and the other side is actually intimately invested onto the lung tissue itself. So therefore, the outer layer of that connective tissue, the layer that is stuck to the walls of your thoracic cavity, is referred to as the parietal pleura. It's this one. And the layer, connective tissue layer that is intimately invested onto your lung tissue is referred to as the visceral pleura. So now, in the future going on, if you hear the term visceral anything, it is basically the inner layer of that connective tissue that is bound to that internal organ. The second term changes, depends on which internal organ it is. So you see parietal versus visceral pleura, think connective tissue layer that surrounds and protects the lungs. If you see parietal and visceral pericardium, connective tissue that protects the heart, right? Parietal and visceral peritoneum, connective tissue that protects your abdominal organs, your digestive organs, and things like that. Okay, so that's how it looks. All right, so here's your thoracic cavity. This is a cross section showing your lung tissue. Okay, you guys understand that's a very short and small circulatory portions called the pulmonary circulation from the right side of the heart into the lungs itself, and then from the lungs back to the left atrium of the heart, therefore completing that short circulatory pattern called the pulmonary circulation. And the whole purpose of that is for gas exchange to occur. Okay. Now keep in mind there's an intimate relationship between the respiratory system and the cardiovascular system. And that's typically why we always talk about these two systems together. Right? What's the purpose of the cardiovascular system?
Pump blood.
Yeah, pump blood throughout the circulation. The heart acts as a central muscular pump. The blood vessels act as conduits, so you can deliver blood, which is basically the oxygen and nutrients to every single living cells of the body. Where do we get that oxygen from?
Lungs.
The air, not the lungs. But the lungs allow you to bring the air from the environment into the circulation. And the lungs will also take the CO2 from the blood and allow you to put it back into the environment around you. Okay, so this is called breathing, right? Ventilation, breathing in, breathing out, allowing for that gas exchange to occur with your environment. Okay, anatomically, we're gonna break down the respiratory system into two separate portions. There's a portion we call the upper respiratory tract, and the other one is called the lower respiratory tract. For the upper respiratory tract, it starts with the nostril. Okay, and then air comes in through the nostril into the vestibule. The vestibule is right immediately inside where you basically pick your nose and stuff like that, right? So it's just when you stick your finger in there and you wiggle around, that's the vestibule. Okay, you can't really dig your finger deeper inside because then it's kind of like, very uncomfortable. Okay, so don't push your finger all the way into your nasal cavity and palpate like your nasal septum because you shouldn't be doing that anyways. Okay, there's not a lot of protection in there, so don't do that because you will induce infection of your nasal cavity. Now, as the air enters past that, it enters this large sinus here called the nasal cavity. The nasal cavity is pretty much empty because there's a lot of air that circulates around there. On the side of the nasal cavity, there are three of these shelf-like structures. Okay, these are collectively called the nasal concha, and underneath that are known as the nasal meatus. Now, imagine you have these shelf-like structures, so it's not smooth. And the reason for that is because as you inhale air, the air is gonna hit these shelves and start to tumble around. As the air tumbles around, it creates a lot of turbulent flow in that air so that you can warm up that air, so that you can humidify that air, and you can also trap some of the dirt and debris from the environmental air that you have just inhaled. Okay, so the nasal cavity is made for that purpose. So it's sort of like throwing the air into a washing machine or a dryer or whatever, and it tumbles around, right? And it heats up, the air heats up a little bit, it gets humidified, so it becomes a little more moist, and therefore, all these mucosal surface also trap a lot of debris that you inhale, okay? Now, once that happens, the air is then diverted back into this long tubular structure located in the back. We call that the pharynx. The portion of the pharynx that is immediately behind your nasal cavity is known as your nasopharynx. Okay? And there's a portion of the pharynx that's right behind your oral cavity, your mouth, known as the oropharynx. There's also another pharyngeal portion right here that is right behind this structure called the larynx, called the laryngopharynx. And then air is diverted anteriorly through the larynx, because below the larynx is your trachea, and the trachea belongs to the lower respiratory tract. Okay, so all of these structures here, down all the way down to the larynx, belong to what we call the upper respiratory tract. Now, the reason why we divide it out this way is just to anatomically learn it that way, and also clinically help you to divide the respiratory system into two regions. So if you have, let's say, a sinus infection, some kind of pharyngeal infection, right? Just some kind of nasal infection or whatever it is, or even laryngitis, those are all considered to be upper respiratory tract infections. So you guys have heard that term before, right? And it's easier to treat upper respiratory tract infections before it basically starts to descend down into the more microscopic, deeper structure of the lungs and cause a more massive infection. Now, the lower portion of the respiratory tract is referred to as the lower respiratory tract, right? So it starts with the trachea, which is right below the larynx. The trachea, as it descends into the thoracic cavity, will divide into what we call the primary bronchi. Each primary bronchi will enter the lung, one on the right, one on the left. Now, the right lung has 3 lobes, and the left lung only has 2 lobes. So therefore, the primary bronchus will divide into branches per lobe. So we call each of those the secondary bronchi, or the lobar bronchi. So on the right lung, it has 3 secondary bronchi. In the left lung, it only has 2 secondary bronchi. Each secondary bronchi will further divide into smaller type of tubes called the bronchioles. Tertiary bronchi. Tertiary bronchi then further divide into smaller microscopic structure called the bronchioles. The bronchioles then divide into what we call the terminal bronchioles. Terminal bronchioles divide into the respiratory bronchioles. Respiratory bronchioles become alveolar ducts. Alveolar ducts ends with the alveolar sacs. An individual air pocket are now known as your individual alveolus, which makes up your alveoli. Okay? So therefore, if you think about it, per lung, you have one primary bronchus. And as it divides, eventually, you're gonna have approximately 150 million to 200 alveoli per lung. Collectively, you have more than 300 million alveoli in both lungs. Okay? All right, since we're talking about physiology here, we're gonna take all of these anatomical structures and we're gonna divide it into 2 types of zones. One is called the conducting zone, and the other one is called the respiratory zone. The conducting zone, its job is simply to conduct air from the environment into the lungs, from the lungs back out into the environment. Make sense? Just conducting the air. The respiratory zones are responsible for the diffusion of gases between the lungs and the blood. So hopefully, as you inhale air from the environment, the oxygen content will eventually diffuse within these respiratory zones from the lungs into your blood. And the CO2 from the blood will diffuse back into the lungs so that you can exhale that CO2 out, okay? Of all of these structures in the respiratory zone, the alveoli is where 99.5% of all gas exchanges occurs between the lungs and the blood. So these are just these anatomical structures showing the conducting zone versus the respiratory zone. Okay. Gas exchange can actually start somewhere in the respiratory bronchioles into the alveolar ducts, right? But most of those gas exchange will basically end up being in the alveoli itself. More structures showing that. Okay. So again, function of the conducting zone, transport the air to the lungs, warm up the air, humidifies the air, filters the air, cleans the air, right? Now, the cells that make up the vast majority of these structures are known as pseudostratified columnar epithelial cells. And on the surface of those pseudostratified columnar epithelial cells, there's a bunch of cilia. And the cilia all move. You guys remember the motile cilia we talked about once upon a time, right? So therefore, all these cilia move. Now, also highly associated with those pseudostratified columnar cells are a bunch of goblet cells. The goblet cells produces and secretes mucus. So therefore, as the mucus is secreted, it traps the dirt and debris along the passageway of the respiratory, the conducting zone. And the cilia on the pseudostratified columnar cells starts to move all of those trapped dirt and debris in the form of mucus up the respiratory tract, okay? So therefore, we call this collective functions of the cilia and the mucus being produced by the goblet cells. We call this the mucociliary elevator, okay? So let's say in your lungs, you inhale a bunch of, dirty air or whatever it is, right? Of course, a lot of dirt and debris has already been trapped, but then it may get all the way into your lungs, depends on the strength of that inhalation. Now, the goblet cell secretes a bunch of mucus, trap all that dirt and debris. The cilia moves that up, that respiratory tract, to a point where it triggers a cough reflex. So therefore, you can cough and expectorate all that mucus back out, right? So now, along the way, along the conducting zone, through the larynx, you have this area that allows you to produce voice, okay? So the larynx has these folds, and within this fold, you have this ligament called the vocal ligament, and all these structures are attached to skeletal muscle, so you can actually move the vocal ligament in and out like this. You can also shorten and lengthen the vocal ligament if you want to. This changes the pitch and frequency of sound that is vibrating these vocal ligaments as the air passes through your larynx. Okay? And this is allowing you to, produce different pitches of voice and stuff like that. This is looking in through your larynx using an endoscope. Bless you. So if you look at this, you can see a couple of folds down here. That's where your trachea would be. We call this the subglottic area, or this is the glottis. If you have to ever do some kind of intubation on a patient, which basically means inserting an artificial tube so that you help the patient breathe, this is what you will be looking for. So typically when they insert that tube through the mouth, they have a little camera, because that's a little, whatever, fiber optic camera that kind of follows that thing. So you look for that opening so you can insert that into the patient's trachea. Because the path of least resistance is another tube that is located behind the trachea, and that is called your esophagus. And the esophagus is gonna lead you all the way down to your stomach, okay? So therefore, if you have to ever do this blind intubation, let's say if you work in a region where it's remote and you don't have this particular machine that shows you in the right area and stuff like that, and you have to blindly get into the patient's mouth and try to intubate the patient, most of the time you will go down the wrong tube. So typically in the hospital, if they do an intubation, what do they do to check? They take a portable chest x-ray, right? Because there's a line that when you take a chest x-ray, you can see that line. That line basically is along that tube. So therefore, if that line is in the right place, then you know you're in the right place, okay? If you're in the field and you don't have a portable chest x-ray with you, what can you do to check to make sure that the tube is in the right place? Well, you always have your stethoscope, right? So therefore, let's say you intubate the patient, you turn on the machine, let the air flow through, and you check. You take your scope and you put it in the left upper quadrant. Why left upper quadrant? Because that's where your stomach is. What happens when you introduce air into a fluid environment? The stomach is always filled with some degree of fluid. What happens? Go home, take a straw, and start blowing into that water. What happens to the water?
It's gurgle.
Bubble. That's what you try and listen for. If there's a hyper gurgling sounds, you're in the wrong place. All you have to do is retract that tube slightly and aim it forward. Okay. Nowadays, with the advances of this, you guys probably never will have to do a blind intubation. But there are times when you will have to do one of these stuff, especially if you work in the ER or maybe you're a first responder. You kind of, go on. If you ever work like with the helicopter rescue people, it's a great way to get a lot of experience. Okay. Anyhow, just aim for that. First time I did this, it was on a incarcerated patient. Patient was in jail, and this was in Bakersfield. So patient was in jail, but I think they were having inspection, and the patient swallowed. He had a razor blade, and he wrapped it around some paper. He swallowed it because he didn't want to get caught. Right? Of course, inside the paper, it's disintegrated and lacerated his intestine. So he's bleeding internally, passed out. They took him to the ER, and we had to intubate him because he was basically, losing consciousness. So he actually expired. He died. And as we tried to intubate him, he started to vomit all over the place. So it's a failed intubation attempt on my part. But I didn't kill the patient. The patient was already expired. Anyway. All right. Skip ahead a bunch of structures all the way to this structure called the alveoli. So these are the microscopic structures that basically is the functional unit of the lungs itself. This is where the vast majority of the gases will be exchanged between the blood, the lungs and the blood, and the blood and the lungs. Okay? So the cells that make up this alveoli are only one cell layer thick, so they are squamous cells, essentially. And these squamous cells will facilitate that rapid diffusion of gases. Now, in addition to all of those squamous cells, which are known as your type 1 alveolar cells, or type 1 cells, right? This basically makes up the overall surface of your alveoli for the purpose of gas exchange. In addition to those type 1 cells, you also have a bunch of cells called the type 2 alveolar cells. These type 2 alveolar cells, or type 2 pneumocytes, basically they will secrete a substance called pulmonary surfactant. Pulmonary surfactant is highly hydrophobic. It has a bunch of phospholipids and things like that. So therefore, it basically resists the interaction of water, kind of break down or break apart the water interaction and stuff like that, right? So this increases, or this basically what it does is to decrease the surface tension on the surface of your alveoli. Okay? Because the surface tension is produced by a thin layer of fluid that is on the surface of your alveoli that is trying to collapse the alveoli. So just imagine. You have your alveolus. And then this is another cell. All right, so these are your type 1 alveolar cells. Oops. This is your type 2 alveolar cells. Keep in mind that the center of the alveolus is filled with air. The air that you inhale from the environment, the air that basically is moving into that from your lungs. The type 1 alveolar cells will secrete a very thin layer of fluid. And this thin layer of fluid essentially just covers the surface of all of these cells. Okay, just make sure you understand this fluid does not fill the alveolus, otherwise it defeats the purpose of that. It just covers the surface of these cells to expedite the diffusion of the gases, right? Because remember, inside the cell is the cytoplasm, which is fluid dominated, so therefore you want air to easily transition into an air interface into a fluid environment itself. So this layer of fluid here is going to exert hydrogen interaction. Whenever water is around a very small enclosure, the water interact with each other through hydrogen interaction. And what does the water want to do as it basically interacts with each other? It's going to collapse the structure together. Okay? So therefore, it produces a surface tension which pulls the alveolus in. So we call that the surface tension. Now, we need to have something to reduce this surface tension because we want to keep this alveolus open all the time so it can be filled with air. Otherwise, if it collapses, it is very, very difficult for the alveolus to pop back out. Okay? So, this type 2 alveolar cell will secrete a substance. And that substance basically is secreted into this water, this fluid layer here. And this substance is referred to as pulmonary surfactant. The job of that pulmonary surfactant is to decrease the amount of hydrogen interaction of the water molecule. And what it does then is to reduce that surface tension. It doesn't get rid of that surface tension altogether, it just reduces the surface tension. So there's a fine interplay between the pulmonary surfactant and the surface tension of that water. Because you don't want to get rid of that surface tension altogether, because then the alveoli will just expand exponentially and just explode. But you don't want that surface tension to be so strong that it will just collapse that alveolus. Because if that's the case, then you will not be able to exchange the air from the lungs into the blood. Make sense? So, there's a third cell inside your alveoli. We call that the alveolar macrophages. These are your resident macrophages that roam around and they'll just eat up any kind of cellular debris or any kind of pathogen that may have entered this particular structure. Okay? So therefore, if you don't have adequate amount of pulmonary surfactant, what's going to happen to your alveoli? It's going to collapse. And this is what happens to premature babies. Because if the babies are born premature, their body doesn't have enough time to produce adequate amount of pulmonary surfactant. So when they're born, they're in some state of respiratory distress. Okay? And that's why premature baby typically has to be placed inside the NICU, the neonatal unit, right? So that they can have this negative pressure, environment, so that their lungs can expand easier, and so that gives them a chance to produce adequate amount of pulmonary surfactant. What happens if you're an adult and something causes your type 2 alveolar cells to no longer produce an adequate amount of pulmonary surfactant? Your lungs will also collapse. Well, not your lungs, but your alveoli. And we call that acute respiratory distress syndrome. And that's what happens in COVID. Okay. Why does that happen in COVID infection? Because the SARS-CoV, that virus, love to infect the type 2 alveolar cells. When it infects the type 2 alveolar cells, what happens to that cell? It gets destroyed. If it gets destroyed, you no longer can produce adequate amount of pulmonary surfactant, so then your alveoli collapse. If one collapses, it's not a big deal. We have 300 million of these guys, right? But 25% of those guys collapse, you can't breathe. Okay? And that's the reason why a lot of those patients, in the extreme cases, will need that ventilation, that intubation, so that they can live, the machine can breathe for them. Induces a lot of positive pressure to kind of hopefully keep those things open. Now, why is it that when you have COVID in some patients, and we're talking about like really early COVID, not so nowadays, right? Because the strain becomes less and less virulent. But the original strain of COVID that happened years ago, right? Why is it that those patients also have multi-organ failure? Because COVID doesn't attack the other organs. Because if you collapse the alveoli, you cannot exchange adequate amount of oxygen. So you cannot allow for oxygen to diffuse into the blood. Doesn't matter if the heart's pumping, it's not delivering adequate amount of oxygen. So eventually, the kidneys fail, the liver fails, the heart fails, and the brain fails. And that's how you die. Okay? That's the systemic involvement of COVID. When did we get that pandemic notification? When did they cancel classes? I remember in the fall, right? Oh, March.
March.
Spring. Yeah. But did you know the first case, or the first reported case was basically in December? The
Yeah.
first US case was actually in August of the previous year. Yes, they thought that person died of the flu. They reinvestigated, that person had COVID. So we already had the virus all the way in the middle of the previous year, before the pandemic hit. That's what I'm saying, international travel. All right, so here's the alveoli, or one alveolus. Here's your capillaries, pulmonary capillaries. See how close they are next to each other, right? So therefore, the oxygen from the alveolus will diffuse in here, the CO2 from the blood will diffuse back out. And that's how you exchange the gases. All right, a couple terminologies. Just another 15 minutes and we're done. Because we have to cover a lot of this stuff since we lose Monday. Of course, I have to record the lecture for you guys as well, right? If we don't finish it by Wednesday, whenever it's left over, I'll record it for you guys. And you guys are expected to know that on the exam. Okay, so a couple terminologies. When we talk about breathing, we're talking about exchanging gases from the environment into our lungs. Either inhaling the gas or exhaling the gas. We call that ventilation. Okay? And ventilation, as we'll talk about later on, is a mechanical process. You have to engage muscles in order to change pressures so you can get air out or bring air in. Okay? The second process of gas exchange is known as external respiration, which means once you inhale that air into your lungs, there's a diffusion process that occurs between the alveoli of the lungs and the capillaries of your pulmonary circulation. That exchange of gas is referred to as external respiration. Once the oxygen has now been delivered to your blood and that blood returns to the left side of the heart, the left ventricle ejects that blood out high in oxygen content throughout the systemic circulation. Once that blood reaches the capillaries of the systemic circulation, and there's a series of gas exchange between the systemic capillaries and the cells and tissue of your body, we call that internal respiration. Okay? And what the cell does with those oxygen is referred to as cellular respiration. Because if the cell takes in that oxygen and secrete out CO2, that's basically the cell breathing, right? So that's called cellular respiration. Well, of course, we know what cellular respiration is, right? What's the purpose of that? To make ATP. Remember the purpose of that? Yeah, sure. That was like 3 centuries ago. Let's talk about the physical aspects of ventilation itself, the mechanical process of how we can breathe in and breathe out. So remember, air most likely is going to move from an area of high pressure to an area of low pressure. So in order for you to inhale or exhale, you have to create a pressure gradient for the air to move. Okay? Now, in order to do that, you need to change what we call the pressure inside the lungs in relation to the pressure of the atmosphere. Because there's a pressure in the atmosphere here that is produced by the collective gases within the atmosphere. And there's also a pressure inside your lung produced by the collective gases inside the lungs and all these structures of the lungs as well. So therefore, those two pressures typically equate each other. They're the same. But in order for you to breathe in, you need to create a pressure gradient. Does that make sense? Okay. Now just think about that, okay? And then we'll talk about that a little bit more. The third way to basically allow for ventilation to be achieved is intrinsically, the lung tissue has to allow for that to happen quickly and easily. So therefore, the lung tissue is highly compliant. You guys remember the term compliancy is basically a term that refers to any structure that can stretch very easily to accommodate volume changes rapidly with relative ease, right? There's not a lot of resistance to their stretching to accommodate air or whatever the case is, right? So if something is not very compliant, it's stiffer. If something is more compliant, it's basically more pliable, it's stretchier, okay? The other property of the lung is that it has high degree of elasticity. So therefore, because of its compliancy, it can stretch to accommodate air, but once you exhale, it needs to recoil back to its original shape. Okay? If you stretch something and it can't recoil, then it becomes floppy. If that's the case, then the lungs can no longer function adequately. Because remember, inhalation and exhalation is continuous with each other. Okay? And the third property of the lungs that allows for you to basically take in air without blowing up the lungs altogether is this inherent surface tension, this guy. Okay? So this is why the surface tension is important, because the surface tension opposes expansion of the alveoli during inhalation. When you're breathing in, you're bringing air into your lungs, the alveoli will expand. The alveoli is made up of a bunch of cells. So, and it's also surrounded by a bunch of tissue. So therefore, the alveoli can only expand to a certain degree, right? And of course, to aid that and prevent that overexpansion of the alveoli, you also have what we call the surface tension. Because the surface tension is going to pull everything back in, right? Because what the surface tension is trying to do is collapse the alveoli. So therefore, it opposes distension of the alveoli during inhalation. Does that make sense? So that's the reason why we cannot inhale indefinitely. Try inhaling as much as you can. See how long you can gauge that inhalation. Done.
A minute.
It's not like you 2 hours ago, 2 hours later, and you're still inhaling and stuff. No, it doesn't work that way, right? Because there is an intrinsic tissue that prevents that alveoli from expanding. There's also the surface tension that as the alveoli expand, it's going to pull that alveolus back to prevent that overexpansion of the alveoli. You don't want that thing to blow apart. Okay. All right, a couple of terminologies for you guys. So we have what we call the atmospheric pressure, which is the pressure in the environment around you. Okay? That atmospheric pressure changes based on the elevation that we live in. At sea level, that atmospheric pressure is roughly about 760 millimeters of mercury. Okay? That is the collective amount of air in the environment that is added together to give you that total pressure. Inside the lungs, we have the collective pressure inside the lungs called the intrapulmonary pressure or the intraalveolar pressure. Collective pressure inside the lungs. Keep in mind that intraalveolar pressure opposes the atmospheric pressure. They're playing with each other all the time. Okay? Now, there's also another pressure we call the intrapleural pressure, because between the parietal pleura and the visceral pleura, there is a space filled with fluid, okay, called the pleural cavity. So therefore, because it's fluid, there is a pressure exerted by that fluid, and we call that pressure the intrapleural pressure. So, as far as the lung is concerned, let's imagine that's the lung tissue, right? Here's the atmosphere. So this is atmospheric pressure pushing into the lungs. Inside the lungs, you have the collective intrapulmonary. Or we call it the intraalveolar pressure. Okay, it's pushing back out this way. Now, remember there's two layers, right? So there's an outer layer called the parietal pleura, and there's an inner layer called the visceral pleura. So let's say there's a little cavity that also exists here. It's filled with fluid. So that fluid is going to push against the lung tissue. So therefore, that pressure produced by that fluid is called the intrapleural pressure. So this intrapleural pressure is always trying to collapse your lungs. Okay? The intrapulmonary pressure is pushing the lungs back out. So therefore, the intrapleural pressure actually has two pressures that it has to oppose. It has to oppose this pressure here, and it also has to oppose the atmospheric pressure as well. Okay? So just think about this, right? If you want to breathe in, let's say both of these pressures are pushing against each other, and it causes air to kind of even go in and out evenly. If you want to inhale, what do you need to do? Which pressure has to change, or which pressure has to become greater than the other? Let's say between these two, to make it easy. The atmospheric pressure and the intrapulmonary pressure. Which one do you want? Do you want the intrapulmonary pressure to be higher or lower than the atmospheric pressure?
Higher.
Who wants it higher? Ed. Who wants it lower? Okay. If you lower the intrapulmonary pressure, air is going to move from high pressure to low pressure. Therefore, that's inhalation. Okay. If you're exhaling, now you want the intrapulmonary pressure to become higher than the atmospheric pressure. Of these two pressures, which one can you change? You cannot change the atmospheric pressure. So the only pressure you can change is your intrapulmonary pressure, right? It's not like if you snap your finger and you transport yourself from here all the way up to Mount Everest, oh yeah, you can change the atmospheric pressure immediately. You probably die because there's so much nitrogen and very little amount of oxygen up there that you're like immediately like, oh my God, where the hell am I right now? If you snap your finger and all of a sudden now you're on the bottom of the ocean, well, you know, obviously bad things happen. You can't breathe down there anyways, right? So in either case, you cannot change that atmospheric pressure unless you have that ability to basically, you know, zip yourself back and forth in an instant. But we can't. Even if we walk up 2 flights of stairs and walk down, the atmospheric pressure is still the same. We're still at sea level relatively, okay? So therefore, the only pressure we can actually change is the intrapulmonary pressure. Now, what happens when you are inhaling and exhaling? What is going on with these two pressures? Which one do you think has to be higher all the time? Well, you can ask yourself, do you want your lungs to stay inflated or do you want it to collapse? If you want it to stay inflated, the intrapulmonary pressure must always be higher than the intrapleural pressure. Okay? Which means if the intrapleural pressure all of a sudden becomes higher than this pressure, what happens? It's going to push the lungs all the way in, collapse the lung. There are penetrating wounds that we've seen in the ER where it penetrates. Let's say the patient got shot and penetrates through and basically causes sort of like a suction effect into this pleural space. Air from the environment rushes in, but it can't move back out. And so you exponentially increases the intrapleural pressure, which then forces the lungs to collapse. And the patient can't breathe. Okay? So one of the things we do is we basically place a little, like needle with a valve into the space between the second intercostal space, mid-clavicular line. So basically you aim for that area, place that needle in, you turn that valve, and it release that air out from that intrapleural cavity. The lungs then reinflate, and the patient's, oh, thank you for saving my life. Here's my life savings. So that's probably gonna charge me that much anyways, right? All right, there's another pressure called the transpulmonary pressure. And the transpulmonary pressure is just the difference between the intrapulmonary versus the intrapleural pressure. So transpulmonary just basically means just a difference in pressure between two areas of the body. Okay, so one of the things to kind of keep in mind is that in order for you to inhale and exhale, in any enclosed structure, if you have volume changes that can rapidly be induced in that structure, it must be coupled to pressure changes within that structure as well. Volume and pressure basically interplay with each other all the time. You guys remember when we talk about the cardiac cycle, we have pressure changes. As the pressure increases, the volume decreases and stuff like that, right? So therefore, in the lungs, it's the same thing. And we call this Boyle's law. Boyle, Dr. Boyle, basically created this law in physics mainly. And this talks about any type of system, any enclosure that can rapidly change volume and therefore must also rapidly change pressure to accommodate that volume changes. So change in pressure and change in volume is inversely proportional to each other, according to Boyle's law. So in the lungs, if you want to increase volume into the lungs, you need to decrease the pressure within that lung tissue. If you want to decrease the amount of volume inside the lungs, all you have to do simply is to increase the pressure of the lungs, okay? So therefore, to breathe in, you need to decrease the intrapulmonary pressure. To breathe out, you need to increase the intrapulmonary pressure. Make sense? Pressure volume inversely proportional, okay? So inspiration, breathing in, means that you have to create this change in the intrapulmonary pressure to become lower than your atmospheric pressure. To breathe out, all you have to do is simply mechanically increase this intrapulmonary pressure above the atmospheric pressure. Imagine the atmospheric pressure is unchanging, so all you have to do is decrease this pressure in order for you to breathe in, increase this pressure in order for you to breathe out. That's it. Okay. How much pressure change do we have to produce? All you have to produce is about 3 millimeters of mercury in difference to the atmospheric pressure. Okay? So in order for you to breathe in, you need to decrease the intrapulmonary pressure 3 millimeters of mercury below your atmospheric pressure. That's what the -3 stands for. Okay? Below or above atmospheric pressure. So imagine, take your atmospheric pressure and put it at a 0, which is a reference point. It has some measurable number, but now let's just say it's at 0. So if you want to breathe in, all you have to do is drop your intrapulmonary pressure, decrease this pressure 3 millimeters mercury below the atmospheric pressure. That's enough for you to take air into your lungs. In order for you to breathe out, you need to increase the intrapulmonary pressure 3 millimeters mercury above the atmospheric pressure. That will force the air out of your lungs. Okay, so that's what the +3 is for. Now, all the while you are inhaling and exhaling, your intrapleural pressure, this pressure in here, must always stay more negative than the intrapulmonary pressure. So if you are decreasing the intrapulmonary pressure 3 millimeters of mercury below the atmospheric pressure, then you need to reduce the intrapleural pressure 6 millimeters of mercury below the atmospheric pressure. Because if you're inhaling and you're reducing this intrapulmonary pressure of 3 millimeters of mercury, and you don't change this thing, then that's gonna collapse your lung altogether. So therefore, this pressure must now become much lower than this pressure in order for the lungs to stay inflated. Okay. All right. Compliancy, we talked about that. Ease of stretching of the lungs, right? Higher compliancy, easier for it to stretch to accommodate volume. Okay, so that's very important for the properties of the lungs in order for you to breathe in and breathe out. If you guys wonder how hard it would be if this compliancy changes, go visit hospice care and go talk to an end-stage COPD patient. A patient who has COPD that is now on oxygen, which is basically, if they're in hospice care, they're just waiting, for comfort care, and they're just waiting to pass. So therefore, go see those patients struggle as they sit up from their bed. I worked in hospice care for a month, and it was like the weirdest experience I've ever had, because it goes against everything that you're trained for in healthcare. In healthcare, you're trying to do everything to basically maintain life. Here, you're trying to do everything not to maintain life, but to ensure comfort as the patient is now transitioning into the afterlife, right? Because that's what hospice care is. That's basically just comfort care overall. So therefore, if the patient was brought in for a diagnosis and the patient has a DNI, DNR, whatever it is, if the patient has some kind of symptoms or flare-up based on that diagnosis, you don't do anything. If you do something to correct that, you will be sued, because that is against comfort care, right? That's an end-stage diagnosis. You're not gonna cure anything, you're just prolonging their death or prolonging their inevitable passing and stuff like that. So now you're actually causing more harm than you are just allowing them to peacefully transition, right? So therefore, please go and work in hospice care. You appreciate your body so much more. I had an end-stage COPD patient try and get up from her bed. It took her literally 10 minutes to move 25 degrees, right? And the bed is already elevated, and she's just struggling to get up, and she can't do it. So Once that lung goes, once the body fails, it fails spectacularly. Because that's just the way the body goes. All right, the other function of the lungs is also elasticity. Again, if you don't have adequate amount of elasticity, as you stretch the lungs out, it cannot recoil back. So now it's a floppy lungs. So if it can't recoil back, you can't increase this intrapulmonary pressure adequately for you to breathe out. So for those patients, they can breathe in, but they can't breathe out. Equally bad, right? And then surface tension, we talked about that. It resists this distension so that you don't blow your alveoli away. Don't worry about the law of Laplace. The law of Laplace used to be called the law of Young-Laplace, and they both stole this from their graduate student, which is what everybody does. So you want to have your names placed on something, hire good graduate students. Yeah. And then eventually Laplace says, hey, you know what, Young? I'm going to kick you out too. So he just called it the law of Laplace. When I learned this, I learned this as the law of Young-Laplace. Okay. That's a long time ago. But anyway, this law just basically kind of gives you an idea of the interplay between the amount of pulmonary surfactant and the surface tension. So just think about it this way, just to quickly talk about this, we don't have to get into the details of this. If you have a lot of air placed into this alveoli, let's say when you're inhaling, the air is going to be distributed differently based on where that alveoli is. So therefore, let's say if there's a group of alveoli that receives more air, that means it's now distended, okay? If it's more distended, you want that surface tension to be higher to match with that distension. So in those alveoli, you can predict that they will have less pulmonary surfactant because you want that surface tension high to prevent that distension, okay? So if you have a lot of pulmonary surfactant, it's going to reduce the surface tension and it may increase the risk of damaging that alveoli because there's nothing opposing that distension. On the other hand, if you have a group of alveoli that does not have a lot of air, which means it's now less in diameter. So now the surface tension is pretty high, so therefore what you want to do is to reduce that surface tension. So according to this law, you can kind of predict in a smaller alveolar group, which means has less air, there's a lot more pulmonary surfactant secreted into that alveoli. Okay? Because the higher degree of pulmonary surfactant is going to reduce the surface tension, therefore reduce the chance of collapsing this alveoli. So it's all interplay. So you have to think about the physics behind all of that. Okay? Because I told you guys, there's a lot of physics involved in the respiratory system. Well, some of you guys. We can stop here. We'll go to the lab. You guys do the lab activities, and then I'll explain the rest of this mechanics of breathing and stuff like that, and talk about the lung volumes and lung capacities. Okay? You guys have a better understanding.